Let's begin with a simple palpation of the shoulder. Start with your palpating hand on the front of your opposite shoulder. It's going to be important to get the starting position correct. Take the hand of the shoulder that we're palpating and place it behind your back. You know you're in the correct starting position if you feel a bone poke out underneath your palpating fingers. This is the greater tuberosity of the humerus, specifically the superior facet, which is the point of attachment for the supraspinatus tendon, the most commonly injured rotator cuff tendon. Palpate by moving your fingers medial and lateral. Is it painful? It should not be. If it's painful, it may note that there is a tendonitis or impingement or even possibly a tear. Now take your hand and move it back to your side. You will feel the bump underneath your palpating fingers disappear. And then as you externally rotate your arm, you will feel the fingers of your palpating hand fall into a little groove. That little groove is the bicipital groove, the home and the pathway of the biceps long head tendon, the second most impinged shoulder tendon. First is the supraspinatus. Second is the bicep long head tendon. Is that tender? That tendon runs inferior superior in that groove and may be tender to touch if it is impinged. Now keep externally rotating a little bit further and you'll feel your palpating hand land on a little bump. This is the lesser tuberosity of the humerus and the point of attachment for the subscapularis. Subscapularis, an internal rotator of your shoulder. So from this position here, subscapularis tendon, bicep long head tendon, and supraspinatus tendon, all before you actually even move your palpating hand. Supraspinatus, bicep long head tendon at 45 degrees, and then the subscapularis tendon. Now place your palpating fingers from the superior portion of that bicipital groove and move them an inch below. From this point, you're still in the groove, you're on the inferior edge of it, and you'll be able to feel three key tendons. From lateral to medial, it's helpful to remember the acronym PLT or pilot. The lateral lip of that intertubercular groove is a point of attachment for pectoralis major. The floor of that groove is latissimus dorsi, and then the inner lip of that groove is teres major. So P, L, T. Those are palpated below the three tendons we just palpated previously, the supraspinatus, the bicep long head, and the subscapularis. So pectoralis major, latissimus dorsi, and teres major. No need to move this arm because we want that bicipital groove to be most anterior, so we can palpate the groove itself and the medial and lateral lip. The lateral lip is pectoralis major, the medial lip is teres major. Let's try palpating some key bony structures. If you just take your hand and grab your shoulder, the square part of your shoulder is the acromion process. Remember, that is part of the scapula, the bone on your back, and it articulates with your collarbone or your clavicle. So if you grab the square part of your shoulder, you are on the acromion. As you put your fingers on top, you are on the top of the acromion. This is important to palpate here because the impingement of the supraspinatus and infraspinatus tends to happen just underneath it. If you take your hands and you palpating fingers and put them on the top of the acromion, and then take your involved arm and adduct and internally rotate and then fall off that acromion, you will be on the infraspinatus tendon that sits on the middle facet of that greater tuberosity. So infraspinatus is the second most injured rotator cuff muscle, followed by the supraspinatus due to its proximity to that acromion. So that's how you palpate infraspinatus. You find the acromion, fall off the lip of the acromion, adduct and internally rotate the humerus slightly, and you will feel the infraspinatus tendon. Okay, if you follow the clavicle, the collarbone, sometimes some people feel it easier to start in the middle and palpate out. You can start here. The bony prominences here on either side of this divot, this top of the sternum or the manubrium, is the sternoclavicular joint formed by the medial clavicle articulating with the manubrium or the upper part of the sternum. This is important to palpate because the first part of arm elevation occurs with the clavicle rotating with its axis at the SC joint. The SC joint says the medial clavicles should be lined up symmetrically. You may notice on yourself or some of your patients that the involved medial clavicle is either more anterior or forward or more posterior or backward. That misalignment or mild subluxation of the medial clavicle may be the cause of impingement when you lift your arm up over your head. So it's important to be able to palpate the medial clavicle. And then as you follow the sinusoidal shape of the clavicle to the acromion, you will feel the acromioclavicular joint, a divot at the top of your shoulder. Another point of potential impingement. The last thing I want you to be able to palpate today is the fascia around the AC joint, around the acromioclavicular ligament. Take your fingers and just skin roll. I'm going to show you skin rolling here on my bicep. You should be able to pinch the skin and kind of roll it. And it should not be tender or painful. So same thing goes here. Try to grab the skin on the superior portion. I'll try to turn my shoulder of the AC joint and see if you can roll it. Compare it to the other side. It should not be tender. Tenderness in the fascia above the acromioclavicular joint is common in people with impingement syndrome of the rotator cuff. Okay, that's shoulder palpation part 1. Stay tuned for part 2, where I may have to get a model to palpate the posterior aspect of the shoulder.